Recovery from an eating disorder is possible, and the right support can make all the difference. Today's episode is brought to you by Selah House in Astor Springs. For 20 years, Selah House has proudly guided individuals on their journey to lasting recovery. Selah House in Astor Springs are accredited, specialized eating disorder programs right here in Indiana, providing compassionate, evidence-based treatment for adolescents and adults. Selah House in Astor Springs offers several types of care tailored to each person's individual needs, including inpatient and residential treatment, day programming, and virtual intensive outpatient programming, and all programs accept most major commercial insurance. You can learn more about Selah House in Astor Springs by visiting the link in our show notes.
Hello, everyone, and welcome back to Stop, Collaborate, and Listen, the podcast where we have honest conversations about eating disorder treatment and recovery from every angle. Today, we are talking about something that can bring up a lot of emotions for clients, families, and providers, and that is higher levels of care in eating disorder treatment.
Yeah, so whether you have been personally recommended inpatient, residential, partial hospitalization, or you've supported somebody who has, maybe you're a provider trying to determine when outpatient care isn't enough anymore. I know all of those conversations can feel incredibly complicated. So to help us navigate all of that, we are honored to be joined by Kate Fish, CEO of Selah House, and many other things. Kate has spent more than 20 years working in eating disorder treatment across the full continuum of care. Prior to joining Selah House, she oversaw clinical programming across Odyssey Behavioral Health's eating disorder division, and today she's helping lead the next chapter of one of the country's most established eating disorder treatment programs. So Kate, thank you so much for being here. We are pumped to pick your brain today.
Yeah. I'm pumped to be here, Allison. Thank you for having me. Thank you, Jen.
Of course. We are so excited. I know that Allison and I have personally with our clients have had lots of discussions about higher level of care, when it's appropriate, working through concerns, fears, emotions, all the things with not only clients, but family members and partners. And so we're really excited, like we said, to dive in today. And so before we dive in to hear your wonderful story, how is everybody doing today? It's a Friday. I think no storms today. It's sunny outside. So let's do a quick little check-in before we dive in.
It is a beautiful day, which feels good. And in the spirit of, the evergreen quality of podcasts, let's hope that any day someone listens to this, it will also be a beautiful day. But yeah, happy Friday.
Yeah. Allison, you said you biked to your location. How was it?
It's good. It should be like a 7-minute bike ride. Like it's up the Monon, but I decided to do the big chore of washing and drying my hair today. So I'm just going to naturally sweat the rest of the day. So I should have known, but a little bit of movement tends to like wake my brain up and make me feel a little more present. So I thought that would be a good idea. And now we're less damp, so we can get started.
That's good. It must have been, I also washed my hair today and I was able to drop over to Trader Joe's. And so I have my windows open, like trying to dry my hair out the window. So it's a day for washing hair today. So
yeah. Yes. Yeah.
What's hair washing day is few and far between. It really is a big chore.
It's a big chore.
It would be easier if we didn't have to dry it.
Seriously.
We should use Jen's strategy. Just drive to work with my head out the window.
Exactly. Sometimes I got to use the hair dryer, but it's just a different vibe when I let it air dry. And I'm like, I should do that more often, but then I'm impatient and all the things. So
very freeing. Well, before we dive into the meat of today's episode with talking about all levels of care, we would love to start with your story, Kate. How did you find your way into eating disorder treatment and what has kept you here for more than 2 decades?
Yeah, I've such a boring career because I've only ever done this one thing. I started working in eating disorder treatment and recovery when I was in graduate school and just got paired up with McCallum Place, which was still privately owned at the time in St. Louis, Missouri, which is where I went to graduate school to do my internship. And just immediately was attracted to the idea of helping women and of all ages. And then quality of eating disorder treatment that it's different, I think, from treating other mental health disorders, and that there's this nutritional element and the medical element. as well, which really keeps it interesting. And then eating disorders, because they're not really about food, is really just this kind of umbrella for treating a whole bunch of other diagnoses. And so just kind of immediately I was like, oh, this is not going to be boring, right? It's going to be, just everything was interesting at that point. It's still interesting, but so I never really left that discipline and joined McCallum's team after I graduated, and eventually moved home to Indianapolis and opened my own private practice and focused on eating disorders treatment, and did that for a long time. And then life, is funny and things change unexpectedly. And right around the time that things were changing, I was feeling so clinically burned out. Like after so many years and all you like young therapists out there listening are probably wondering what that means, but it is just kind of this deep sense of like, I cannot talk to another person about what they're eating today. I can't do it, and it becomes, kind of, because we are so self-aware, like, whoa, I need to take a step back. But I don't want to leave this realm, this eating disorder treatment and recovery. So I started focusing on what I see as one of the biggest issues in our area, and that's just the lack of providers who are specialized in this care, and really wanted to tackle that, and got really kind of professionally or passionate about that aspect of my professional life. I was talking to the director of Project Heal, and she was the one who gave me the statistic, which if you've ever heard me give a talk, I use in every single talk, regardless of the topic. But, there's 500,000 licensed mental health clinicians of different disciplines in the United States, and less than 2% of them specialize in treating eating disorders. And as you guys know, 30 million Americans will struggle with an eating disorder at some point in their lifetime. So, to me, those numbers were astounding. And because I never deviated from this topic, I realized what a wealth of information I had and ability I had to start sharing what I do, and helping other therapists, because that's the scope of my practice, although it's not just therapists who we're missing, but helping to share my knowledge and teach other people how to treat this disorder and assess for it, right? And start to help other people realize, hey, this is disordered eating, because when you're not specialized in it, you could spend years with a client and never know what questions to ask to realize, this is a problem. Right around that time was when Odyssey came and said, hey, we just opened an eating disorder division, and we are going to buy a whole bunch of eating disorder centers and build a whole bunch of eating disorder centers. And we realized we don't know what we're doing, because we are a mental health or behavioral health company. And we realize that eating disorders are very different. And will you come and teach our people how to do it? And so I joined Odyssey 4 years ago, started doing that. It was amazing. I got to travel around to different sites, eating disorder sites around the country, and help train their therapists and create clinical programs for them. And then last year, I was given the opportunity to step into the CEO role here at Selah House, which is one of Odyssey's programs. And it has been a wild ride so far. So still very passionate about training, but a little bit of a detour to the operations side of things for right now. I felt like a long story. It's a long story. I guess it is over 20
rich
years.
with stuff. Yeah. I was going to say rich with a lot of like good things in there. I mean, you hit on that eating disorders are not about the food, that they're incredibly complex mental health disorders, right? And particularly, I mean, it makes sense too that you would get burnt out. Like this is not, because of the complexity, it is a challenging population to work with, because there's a lot of different areas that therapists have to, and dietitians and medical providers need to be aware of. I did not realize that there's only so few people that specialize in eating disorders. I think that makes sense. But like hearing the numbers, I'm like, whoa. So I think that's so cool.
Though, right? Professionally, we hang out with other people who are specialized in treating eating disorders. And so I think we're blind we're biased, I guess, in our perception.
Definitely. Before we kind of talk about higher levels of care, what has your experience been like in training other providers? Because that is That's something I've always been interested in. Alice and I both have a background in personal training and have thought about how can I train personal trainers to like recognize things. And so what has that experience been like, particularly after working with clients?
It's just like eating disorders aren't really about food. And I think that calms people down a little bit. Like, hey, you already know what's going on here. It's manifesting differently. I come at training therapists with, you already know what to do. We're just going to teach you some new vocab. And then we're going to get you caught up and really fluent in the nutrition aspect of eating disorder treatment and the medical aspect of eating disorder treatment. And I think that's really, really important. And we know, right, best practices to treat within a treatment team setting, a multidisciplinary treatment team. But it's so, so important to have relationships with people who are in different scopes of practice, because I say fluent, right? I'm only speaking that language. I'm not that, I'm speaking French. I'm not French, right? I'm never going to pretend to be a dietitian, but I need to know, what's going on nutritionally and how it's affecting the body in order to effectively do therapy with a client. And conversely, you as a dietitian need to know the psychological aspects of eating disorder treatment and be able to speak that to understand and do your job the best. So, yeah. So the very first thing that I try and do is empower, or not empower so much as just build confidence in the therapist of, look, you already know how to do this, right? You already know how to empathize. You already know how to build rapport. You already know how to actively listen. You already know how to interpret what someone's saying in a clinically effective way, right? Like, you know this already. Now let's put the right vocab in, the right understanding that this isn't about food, and get you a gang, right? A team that you can call and tackle this as a group. I think that's it mostly.
I so appreciate like the highlighting, like within the eating disorder world, having to kind of be fluent in those other areas that you are not specialized in. I feel like that happens on the dietitian side too, right? When there is no current established therapist, or, you start talking about food and it becomes deeper work, and I'm having to kind of, I'm never wearing therapist hat. Like you said, I'm not French, but if I don't really understand the therapeutic process or like some of those psychological foundations behind eating disorder, I can't really work as effectively. And so I found, even just this week, I had a collab call with a therapist, and I was like, I said some cool words in there that I sound like I might know what I'm talking about.
Did you say enmeshment or countertransference?
Right. A lot of avoidance came up, but no enmeshment. That's a 10-point word. But I think it's great that, yes, we know that there's so few eating disorder providers and practitioners, but also that there's so much learning to be done. And hopefully every healthcare provider feels that way. But I think especially within this niche world, that keeps me motivated and inspired. And I'm so glad you were able to like pivot and still be obviously the huge, huge piece of the eating disorder world, and be able to use your expertise in a different way that wasn't draining you every day.
Yeah. It's so critical. I think, if you ever have a conversation with a dietitian who doesn't treat eating disorders, it is wildly different. And if you ever talk to a therapist who doesn't treat eating disorders, right? It's like, there's the word hypermetabolic syndrome, right? Would be like, why on earth would I know what that is, right? Like, but therapists here in the eating disorder world can explain that from a physiologic standpoint in a second, right? Because we have to understand what's going on. So, and that's what keeps it interesting, and that's why I'm still here and I'm still passionate about it, because it's just different than any other mental health disorder. It really is. But I also think, when we're talking about continued education, like once you know how to treat eating disorders, doesn't mean that, you stop learning or you stop making sure that you know what you're doing for sure, right? And we obviously have supervisioning and peer groups and consultation and such to hold ourselves accountable for that. But, another area I feel like that you touched on when we first started this recording was making sure that in educating and training therapists, we are also making sure that they know how to use the full continuum of care, and when a higher level of care is necessary, and that even higher level of care exists, right? I mean, especially in these like treatment desert areas of the country. I mean, I remember giving a talk in Kansas City, and The founders of a large group practice come up to me and just say, like, how do we get our clients there? Like, they didn't have the knowledge or the experience of ever working with like a business development representative, or like, oh, you call the admissions department and you do an assessment. How much does that cost? You have to make it whoa. Like, it, I was so struck at, like, and this is again because I'm so up close to working in different levels of care, but it's not something that's taught in school, right? It's
Oof. No, it's not. Not a little bit
right,
even. I think I had 1 week
right.
of eating disorders in grad school, and it was like, read these chapters.
Definitely. So yeah, I mean, I feel like that's what I'm doing now. I am speaking. I speak a lot. I developed a talk last winter that I've been running around talking to whoever will listen about. How do we appropriately utilize the full continuum of care, and it starts with just education and making sure that outpatient therapists and dietitians, know how to use it, what it is. Because I feel like that's been lacking. So
Could you give us, as this is a good segue into higher levels of care, can you kind of give us an overview of higher levels of care for eating disorders?
Sure.
Both of us are outpatient providers, and that's typically where we see clients, but also we send people to higher level of care. So could you just give us kind of like a breakdown of what that looks like for our listeners?
Yeah, it's just, when you're talking about it, you need to visualize, it's a staircase, right? And it's a staircase, like all staircases, you can go up or down, depending on what the needs are. But yeah, outpatient is typically like, in a private practice, that kind of goes to your therapist once a week, goes to your dietitian biweekly. That is considered the lowest level of care. And then the highest level of care is inpatient hospitalization. And we're gonna start from the top and go down. But the next rung there is inpatient treatment. So the facility that I run is licensed as an inpatient treatment center. So what that means is we have 24-hour medical staff, access to medical care. We have nurses who are on site 24 hours a day, 7 days a week, and we are working to get the individual medically stable. And there's a specific goal at that level of care. And I may run through, if it's okay, the different steps and then go back and talk about the goals, because I feel like that's the part that really matters and I don't want to jump over it. But so you have this inpatient. Inpatient is typically not that long because it's a couple of weeks, maybe a week, trying to get that person stabilized. Because of the nature of eating disorders, they're from a medical standpoint, they're deadly, right? Like, they'll kill you. And the process of getting treatment is often nutritional rehabilitation or weight restoration. And the process of that is medically dangerous. So, that as we're refeeding, that's what we want to make sure that right at the beginning, the body is responding appropriately. And we put that in the inpatient category. Once those risks are out of the way, they've rounded that corner, they take the step down to residential level of care. This is where medical monitoring continues. And usually in the beginning, there's a lot of oversight to make sure they don't need to step back up as they continue to refeed. But that's a longer level of care. It's a longer treatment stay. Typically looking at, 6 to 8 weeks, 3 months at times. It very much depends on how much weight restoration or how much nutritional rehabilitation an individual needs. Then we step down to partial hospital program. Again, like just a step down. It's a little bit less support. Typically, partial hospital programs run from 30 hours a week, 5 days a week, 6 hours a day, to 6-day a week PHPs that are 10 hours a day. It kind of depends on which one and what their format is. Some of them are standalone. Some of them run concurrent residential programs, like the one that we have at Selah House. This level of care is still continued weight restoration and nutritional rehabilitation, but it's also this introduction to, here's some coping skills that maybe you didn't know about that you can use to replace the destructive behaviors of the eating disorder. Stepping down to intensive outpatient, that's typically 9 hours a day, 3 hours, 3 days a week, and then down to outpatient level of care. So I think the stairs concept makes sense when we start talking about the goals of each level of care. So if we go back up the staircase, right? and we're thinking about inpatient level of care, that is medical stabilization, right? We're not trying to talk to that individual, and this is true for residential level of care. We're not trying to talk to the individual about that, really toxic, dysfunctional family system that they live in and how that's perpetuating their eating disorder. Because when you are malnourished, when you are in starvation, your brain it can't. You can't think about those things. And those are really deep, complex, right? Issues that really the brain is absolutely in fight or flight and it's just screaming, feed me, feed me, feed me. That's all it's going to hear. So we have individuals that come in at that level of care, that malnourished, and it's like, they're not there and they don't really have a memory. There's a lot of repeating, right? The executive functions that our brains have literally get shut off because the brain can't afford to send any energy to that part, right? The brain can only afford, and I realize I'm talking to you guys and you know this, but
No, tell our listeners, please, because they might not.
Yeah.
Yes.
Yeah.
Sometimes it feels weird to go a little bit basic, but at that level, the brain is literally conserving every part of any energy that it can conserve, right? And that's why people lose their period, right? They stop menstruating. The hormones are, essentially those levels go down to baseline because the body can't afford to expend any energy anywhere else than just keeping them alive. And so we have individuals come in, we introduce ourselves, the next day they are upset because they haven't met their treatment team yet. And we come in and we say, yes, we met you yesterday, right? We're going to do it again, right? It is not the time to therapy. So when I think about a treatment team and I think about the quarterback, right, of the treatment team, when we're down at the outpatient level of care, the quarterback is often the therapist. When we're up in the inpatient level of care, the quarterback is that medical provider. When we start to transition from inpatient to residential, the quarterback is really the dietitian. Right? That is where we want to put most of our resources. As they progress through RTC, right? They get better, they get healthier. Literally the lights come on. It is the most amazing thing to see someone literally wake up, like they just like arrive and their personality is back and suddenly they're funny. Maybe they're not so angry all the time. Some people's eating disorders are very angry. And it is 100%, I think, what keeps people in this business of higher level of care is really watching someone transform like that and get enough brain and food that we can start to turn back on their executive functioning and that part of their personality can come back. So that's what the goal of RTC is, right? Is that continued medical stabilization, continued weight restoration, continued nutritional rehabilitation. And I keep saying those two things together. And I think this is a really important part is that you don't need to be malnourished to be medically unstable, right?
Can we say that again for listeners in the back there?
What's that?
I said, can you say that again for listeners in the back there?
I know. Well, listen to this statistic. So only 6% of individuals with eating disorders are medically underweight. And, we could do an entire episode on like atypical anorexia and weight suppression. And right, we might have an individual who comes in to us and they are at their, ideal body weight based on their growth charts, except they've lost 200 pounds in the past 18 months, right? So they are wildly malnourished, may not need to necessarily weight restore, but they have to nutritionally rehabilitate. And so, I say those together because I think that's really important to remember. We're going to get down to PHP, right? And the goal there is, typically you're at 90% of where you're supposed to be once you go to PHP. But the goal there is, hey, here's some strategies that we're going to use to replace the eating disorder behaviors. Let's start practicing those so we get pretty good at it. Let's start talking about what home's going to look like, those kinds of things. And then we go down to IOP. Now they can go out into the world and actually practice those skills and then come back into a supported environment and process that if they are effective or if they need to tweak anything. Then they go to outpatient. Outpatient is where you do that psychological work on what are the cognitive pieces, what are the psychological pieces that are perpetuating this eating disorder. So when I talk about a higher level of care, I am talking about the inpatient RTC partial hospital part of this ramp is greasing the wheels, right? So that individual is going down the stairs, down the ramp, so that when they slide out into outpatient therapy, I hope everyone is visualizing this the same way I'm describing it, but they are sliding into outpatient therapy in the absolute best shape that they possibly can to really be able to engage therapeutically, to really be able to engage psychologically and take advantage of that deep therapeutic work that's necessary for recovery. Right? I mean, but you can't do it if you're not fed. You cannot do it. And that's where we spin our wheels, right? We spin our wheels in every level of care if we are not really clear about what the goals of those levels of care are, and if we're not really clear on how malnutrition affects the brain. And I see it in outpatient therapy. They are waiting too long to refer. They're beating their heads against the wall. I can't get my client to make progress. Well, of course you can't. They're starving.
Yep.
Like, what are you talking about?
Yep.
Of course you can't. And then I see it, working in these higher levels of care too. As I see clients who are staying in RTC too long, that, the therapists are working on doing that deep therapeutic work at an inappropriate level. And it's like, you guys are working too hard. And it's the first thing when my therapists or any of our programs say, hey, we're burnt out, or our caseloads are too high, or I don't have enough time to do things. It's, let's stop and look at what your goals are for the patients, because your goals are too big right now and you're working too hard when that individual is not ready to do that work. So let's reset the goals, right? And set them up to succeed at a lower level of care. And that's also where I encourage that really close communication with the outpatient team and the higher level of care team, because, that therapist is logging this stuff like, oh man, there's some stuff there that needs to be worked out, right? You're not going to work it out right now, but you can name it and you can communicate it to the team that's down at the bottom of the hill waiting to receive that, weight restored, nutritionally rehabilitated individual.
Beautiful.
Yeah.
Loved all that.
What were you doing? Were you snapping?
Yeah, snapping. We love to snap here. Yes. No, I think that was such a beautiful explanation. Truly, truly, truly. And I really love how you highlighted on what the goals are for each level and what is and is not clinically appropriate at each level, which is huge. And so I want to circle back. I know we want to circle back to like outpatient team maybe waiting too long. However, before we do that, I must ask, you painted a beautiful picture. I have not worked with a client who's been able to complete that beautiful staircase step. Insurance might discharge them early from res. Mm-hmm. They might go from res to IOP. Like, we know that is the ideal, the stair step down, but I know that is not always practiced due to a variety of factors. Would you be able to speak to that a little bit?
Yeah. It absolutely is, like, in an ideal world. And when I do it, when I talk on this topic, I get through what I just talked about. And then I show a picture of a unicorn jumping over a rainbow. And I'm saying, because I'm like, now they're fixed. Now this is how you do it. It's perfect. Right. And then we go into what are the barriers to completing, right? And this is a week-long thing that we could talk about, right? If we just want to talk about, insurance and the barrier of insurance, the barrier to access to care. Oh my gosh, only 12 to 25%. I am full of facts today. 12 to 25% of people who need eating disorder treatment receive eating disorder treatment. Right? The therapists in my private practice don't accept insurance because insurance doesn't reimburse them enough for them to make a living. So, that is a huge barrier. And then, there is also this barrier of the egocentric nature of eating disorders too, right? And the confusion and brain lock that happens with malnourishment and starvation, right? Like I talked about, all of this executive functioning really shuts down the ability to see the bigger picture, the ability to have psychological flexibility or any sort of distress tolerance, right? At that level is absolutely muted. And it's really hard to talk an adult into staying for treatment of which is the thing that they're most phobic about. Right.
It's so convoluted. Yeah. And especially like if, my gosh, just everything that you're saying, I'm thinking of clients and anyway, sorry to interrupt because now I've lost my very cool, very important thought, but please continue.
We'll jump in when it comes back to you.
You got it.
So that is really, really hard. And so on the higher level of care end, we work a lot at preventing AMAs. AMA is a discharge against medical advice. It's also against treatment advice, which is if somebody is medically stable. We have a AMA alert team. So the second a client starts talking about discharging too early, we instantly, everybody on their team is alerted. Our alumni coordinator is alerted to find one of the alumni in recovery, to get on the phone with this person and talk about why they need to stay. We immediately contact the outpatient team. Hey, just so you know, this is coming up. Family members. We pull out all the stops because fear is strong, right? And these are people who are naturally avoidant, right? Anyway, and the inclination to flee when things get uncomfortable is real high. So that is a huge barrier as well. We could keep going about family is a barrier. There aren't, and you're right, so many barriers to it. And going back to access to care, we're sitting here in the state of Indiana. There's only one residential inpatient treatment center in the entire state of Indiana.
And you got
access, right?
Yeah, access to treatment. Yeah, the number of clients, that I've had who maybe live in somewhere in Indiana where it would be incredibly inconvenient for them to have to go to higher level of care, right? Like figure out there's so much there that they're like, well, what do I do now? So,
right.
And I think that's a huge, the barrier to care just being accessible is probably, of course, factored into that, 12 to 25% that receive care. 100%. When instead, I think a lot of eating disorders take that as I couldn't possibly be sick enough to be part of that 12 to 25%. And so just the convoluted nature of the eating disorder itself, to speak to what you said about it just being egocentric and very difficult to even convince an adult person that you actually do need this, I think has been such a challenge.
Right. It is hard to tell an adult, you're gonna leave your job, right? FMLA, and your family, and you're going to go live somewhere that is not in your community. I think that's just mind blowing to individuals who don't have experience with, any sort of mental health treatment, right? Or the levels of care. And that's where outpatient providers need to get really good at being able to explain, no. The work we're doing right now is going to get you to sustained recovery. But we can't do it until you're fed, and you can't be fed at this level of care. And talking about fluency, right? That's where I need an outpatient therapist to be able to fluently talk about hypermetabolic syndrome, right? I need them to be able to say, look, you're going to probably have to eat close to maybe 4,000 calories a day in order for you to start gaining weight. Do you know how hard that is? Especially since you are phobic of food and you probably have gastroparesis, right? You're going to need a tube. You're going to need a drip, and being able to say it's just medically impossible. And no one's going to be there to monitor refeeding syndrome. Being able to speak to the necessity from a medical nutritional standpoint, again, understanding the goals of higher levels is just absolutely critical. Yeah. And there's another piece too of, always being evidence-based, right, is something that I clearly believe strongly in. I haven't met a therapist or a dietitian who doesn't agree with that. But we know it's becoming clearer and clearer that the sooner weight restoration happens, the more likely an individual is at having a positive treatment experience and sustained recovery. So when we allow clients to just hang out at that outpatient level of care, the IOP, the PHP, and they're not weight restoring, we are doing them a disservice, right? And sometimes it's, well, we want to see what they can do. And it's all the time that goes by and they're not progressing in treatment is putting them more at risk of getting locked into this for longer. And when I say earlier, I'm talking about the first 2 to 3 weeks of treatment. When we see weight gain happen, and think about this from a dietitian standpoint, how hard that is, because you got to get the tube in, right? Well, you got to get the meal completion done, and you can't we can't start them at 4,000 calories, right? We can start them a lot higher than ever because we know more, but then we got to increase it. It
No,
is
you're right.
critical,
And they
right?
haven't come a lot of the times, like to speak to your unicorn with the rainbow. Of course, that would be great if when they got down to outpatient, there would be all of this understanding. And instead, a lot of the times we're getting them from the basement and they are like barely open to even coming to an outpatient appointment. And then we're rocking their world and saying, actually, this is not appropriate. And so I'm so glad you highlighted the waiting, because I feel like even early on, it can be very easy to start, and they're very open to saying, no, I'll stay here as long as I don't have to go there, and we'll see what I can do. And yeah, it's a disservice to them because it's just creating this steeper uphill battle. And I feel like I've run into that a lot when people don't have that step down process.
It's failed. We used to call it like the failed intervention, I think, or failed step, where it was really driven by insurance of like, you have to go to the least invasive level of care first and fail before you can go up to the next one. But, now we know, like, we don't have time for those games. We don't have time for that.
Yeah, that's like unsafe medically.
It is. It is. And I think when we have these standalone IOPs and PHPs, which we have to have because we don't have enough care. So it's, not every place can be a center that you travel to, but there's a lot of like, okay, we can't get through to the family or the individual. So we're going to just give them a month at this level of care so that they realize that they need a higher level of care, right? I get that strategy. That makes a lot of sense to me. But if you don't understand that that's actually doing them a disservice and can't communicate that appropriately, right? You don't really have time. We don't have time for them to figure it out on their own.
Right.
I mean, it's so tricky. Now we're just like starting to tread into some ethical conversations too. But yeah, it is so critical that especially when there's weight restoration to be done, that it begins to happen as soon as it possibly can.
Yeah. It makes so much sense. And two, just as you were talking, I'm thinking of just the lack of understanding. I mean, our culture is normalizing eating disorder behaviors as something that is fine, is normal, is okay. And so I think too, I've run into clients who are like, well, I mean, I'm not passing out that much. Well, I mean, like, I can still work, right? Like it's a lot of these justifications, like I'm not bad enough, I'm not sick enough. And I think what you're continuing to highlight here is that like eating disorders are significant and are very severe and can become severe very quickly as well too, which I think a lot of people don't understand, right? Well, they're able to do this or this or this, they should be fine. But like there's a lot going on.
Things that will kill you with an eating disorder are asymptomatic.
Yes.
Right?
Yeah.
For example, a lot of people with a diagnosis of anorexia nervosa restricting type, there's a high correlation of them experiencing asymptomatic hypoglycemia. So you know what it feels like when your blood sugar is low, right?
Yeah.
It's like shaky, maybe nauseous, real irritable. It's like, I need to eat that banana right now. They don't feel that way. And so when they get low, which happens when you don't eat, they don't know it. Their body isn't able to send them signals that they need medical attention emergently, because that'll kill you. I mean, you get down below 30 and your body wants to put you in a coma, like literally, because it's going to shut down. And it's hard once you've gotten to a certain level to return from that, right?
Mm-hmm. Yeah.
Same thing with like low potassium. That's asymptomatic until you get way down there. Or washed out sodium. Somebody's fluid loading, right? And their sodium level is totally diluted. Like that, you don't feel that and you don't see it, right? It's really scary. And going back to the cultural aspect, right? I mean, we live in such a bizarre world where I am talking constantly to patients and families and professionals that I'm educating about the risks of rapid weight loss and how rapid weight loss increases the risk of refeeding syndrome. And refeeding syndrome is basically the body's malreaction to receiving nutrition after a prolonged period of not having nutrition, right? It cannot recalculate fast and things get really wonky and chemically, body can't react fast enough and it will kill you. It'll result in cardiac arrest or stroke. And the faster you lose weight, the more at risk you are for refeeding syndrome, right? So I have somebody who comes in, they're not underweight, right? But like I said, like the atypical anorexia, like they've lost 200 pounds in 18 months, or they just lost 30 pounds in 30 days, right? Like that's terrifying. And then on the other hand, we literally have commercials that are advertising, GLP-1 RA medications where they're talking about lose 25% of your body or body weight. Like no one is talking to that group about this is not medically safe. What are you doing? It is such a disconnect to me. I don't even know where to start with that.
I feel like we say that all the time. You don't get to like send a code to your body and be like, hey, I'm not starving with an eating disorder. I'm just like doing this lifestyle change and it's totally different. It's not. Losing 25% of your body weight is significant. So it doesn't matter the intention behind it or what caused it. It's like when your body has lost that much, it's a medical event.
Yeah. Now we got to go save the world.
Right. Well, that's a good segue for maybe our next section here is you are an active member of REDC, which is a national consortium of eating disorder treatment leaders, focused on like advocacy, improving access to care and best practices. Can you tell us a little bit more about that? I'm unfamiliar with this as well. And why has that work been like so meaningful and helpful for you?
Yeah, it is. We call it Red C.
Red C. Perfect. Lovely.
And it is the consortium. It used to be the Residential Eating Disorder Consortium, but we as a group have expanded our membership to individuals who run partial hospital and intensive outpatient programs as well. It is a group of industry leaders that get together, and we get together quarterly in person. Always, we have one virtual a year, but we sit around a table. Big horseshoe shaped table. There's usually 30 to 40 people there. And it's, the CEOs of Montanito and also, Renfrew, like, all of these industry, everybody is there. Everybody takes off their hat, right? Their corporation and their organization's hat. And they come together just as eating disorder treatment experts. And it is this consortium's goal to develop and maintain clinical excellence standards for the treatment of eating disorders at higher level of care. So if you want to be a member of this consortium, your centers have to meet these standards. And only then are you considered a center for excellence. And there, it is a way to protect the integrity of eating disorder treatment, especially in this culture of behavioral health organizations being bought by large private equity groups that often are made up of board members who oversee these organizations. And these board members do not have behavioral health background. And so I think we saw So we saw that happening and got together and said, as an industry, no. We are all now working for profit, right? We need guardrails. We need to make sure that we are still able to hold these centers accountable for best practice, right? And we have an ethics committee that will go in and start investigating if there's any issues with what somebody's doing at a certain eating disorder treatment center. And I just, one of the things that we also work on is creating a level of care guideline. And that is looking, literally an easy to read, although it's a small print, but easy to read, grid of, okay, I just did an assessment on this client who's seeking outpatient treatment and they are less than 80% of their ideal body weight. They do have suicidal ideations or, passive ideations. They aren't able to consume this amount of food without support or, okay, this adds up to residential treatment, right? And so it's meant to get rid of any confusion about what level of care is appropriate based on how a person is presenting. And it's literally developed by the experts. I'm a young member of the team. I'm quiet. I'm not usually quiet ever, but I'm pretty quiet because when I'm there, because I'm literally sitting at a table with the experts. I'm sitting at the table with the people who've written the books. And, when I'm here at Selah House and I'm trying to continue and develop further, right, the most highest quality program we could deliver, I am looking to these individuals to set the standard for me, right? And so I can't say enough about it. I don't think enough people know about it. And I think if they did, they would understand that a lot of these higher levels of care aren't these scary, big, bad places. And I think that's kind of what happened is there's been some disillusionment after some facilities weren't held accountable for those really high standards. And it's like, well, residential, treatment centers may not be safe to, for our clients or our family members. And we backed away and we started treating higher acuity at lower levels of care and without realizing the risks of that. And so, part of what I want to do, part of what Red Sea does is make sure that like this isn't the Wild West. There are standards and we have to abide by them. And it isn't like, we also have to abide by like accreditation bodies too, right? Like JCO and CARF and these other high organization Department of Mental Health, but this is the group of topic or specific experts, right? Specific to this type of mental health that are setting these standards. So, and they do a lot of advocacy work. We have part of what our membership dues pay for is a lobbyist. So we employ a lobbyist whose entire job is to advocate for mental health parity and eating disorder treatment coverage for our insurance companies. Lives in DC. Like, it's amazing. She's the one, she'll come to our meetings and give us heads up. Hey, this policy is coming down the pike and this is what this means for your centers. And this is how we can, adjust accordingly so you can continue to keep offering high quality care. So it's a neat place. I recommend you look it up online.
Yeah,
So,
we'll stick it in the show notes for sure.
Yes, I didn't know about it before I read your outline. And so I was able to check it out. It seems very niche, very cool.
Yeah. And I can send you guys, you can put in your show notes too, a link to the Red Sea level of care guidelines too. I think it's really handy. And it's also really handy, I think, because a barrier we haven't really talked about, which again is a whole nother show, is, convincing parents, right?
Ooh.
So being able to take a piece of paper that they can touch that was created by the experts, right? And say, look, your kid really qualifies for this level of care and it's scary and I'm going to help you find a great fit.
Yeah.
So,
yeah.
I think the other piece that we noticed when I came into this role, right, it's less clinical and now it's more operational. So I do a lot of like tracking of numbers and data and like who's coming in and who's referring and the financial aspects of it, which is great because I was so clinically burnt out. It's helpful to like learn something new.
Yeah.
But which is also interesting. And I think it's something that I think is really special about Odyssey and all of their sites, which includes Selah House, but also includes Astor Springs brand, Magnolia Creek brand of eating disorder treatment centers. But all of their leaders, like their operation leaders, have to have a clinical background. And that's true for everybody in the C-suite except for the CFO. But like our CEO of Odyssey, so the person at the very, very top, Richard Clark, was originally a psychiatric nurse and is now the CEO of an enormous behavioral healthcare company that owns, almost 60 treatment centers across the United States. So eating disorder division is just one little division and we have 10. So I think that's really important because they want to be able to make operational decisions from a clinician standpoint. So we never get away from putting the client first. And that's something I really, really appreciate about working for Selah and being a part of Odyssey Behavioral Health. But yeah, Selah House has almost a full continuum of care. We have the top 3, right? So we do inpatient, residential level of care, and then a partial hospital level of care. We do have housing for our partial hospital of care clients because we want to reduce that barrier of I can't drive there every day. So they come up and they stay here. And then, we do not have intensive outpatient, but we work so closely with teams around the country. We have a case manager who's phenomenal, who finds, the appropriate outpatient treatment teams and the appropriate step down to IOP wherever our clients are going, because our clients come from all over the country. We are opening in September, our expansion that we've been working on for quite some time. One of the things we noticed was the people coming to us were coming sicker. And I think that has to do with, and this is my theory, right, is that outpatient providers are waiting too long to refer to a higher level of care. And people that come to us are sicker than they've ever been. When I started at McAllen Place in 2005, the, 18-year-old anorexic, restricting type, that came into residential level of care looks so different than who we see come through our doors now. The psychiatric acuity, the medical acuity, it's just astounding. And we do our best at an inpatient level of care in a home-like setting to take care of whoever we can. And so we bought a building. It's on a campus of a hospital, and we totally demolished the inside, took it down to the studs and rebuilt it. And it is a 23-bed inpatient facility. So it's really a place where we can treat, I think, in a better way, those who are medically unstable. And those who are medically stable maybe step down to that residential level of care, but are still in that kind of high risk category. They can stay there. And that opens in September. And then from there, they will step down into our more home-like settings, right? Which I think we're known for the beautiful homes that we have. And it's, our equine assisted psychotherapy program as well. So that's been fun. I'm learning all sorts of things about building an inpatient psychiatric facility, because that's what it's licensed under, right? And the state of Indiana has also been learning that as well, because they don't have one for eating disorders.
Yeah.
So it's been really interesting, but hopefully, again, like, I'm all about removing barriers and increasing access to care. And I feel like, opening a 23-bed facility is going to help with that, and we always have a wait list, which is not a good thing. That's not a good thing. That means there's people out there who need care and they're not getting it. And so hopefully we'll be able to better manage that as well. Monticello is in Anderson, Indiana. And so for those of you who are listening who don't know geography of Indiana, which is probably most people who don't live in Indiana, it is just north of Indianapolis suburbs. It's a really interesting area, but, we wanted lots of property. We wanted to continue our equine program. And so we've landed in a rural part of Indiana, which is still pretty close to the airport and major metropolitan hospitals and things like that. So we kind of have the best of both worlds up here. But we have a teen program here in Anderson and a adult program here in Anderson. Monticello will be a third property that is close by to the other two.
So cool.
Yeah. Yeah, you guys, I'm gonna invite you to the open house and come and see it.
Yes, I'll be there for sure. For sure. Well, thank you so much. How can our listeners learn more about Selah, about you? Where can people connect with you and find you?
Yeah, sure. So selahhouse.com is our website. The number for our admissions team, their admissions team is amazing, is right on our website. I can put it in the show notes as well. And if you feel like even our outpatient providers are able to get more information about us without having to call the admission line, you can call our business development representatives and we can put more contact information in there as well and be able to get a full rundown of what we offer and best fit for your client. And then I like to make myself really available too. I have a lot of, a LinkedIn presence. So if anybody's looking for me, feel free to message me on LinkedIn. And, I really enjoy consultation phone calls and I think this client needs a higher level of care. Where do I start? Happy to talk about all of that. So Thanks for letting me talk about all this stuff.
Yeah.
Gosh, we
This
are
was
so lucky
great.
to let you. Yeah.
Thank you so much. All right, everyone. That is a wrap on our episode about higher level of care with CEO of Selah House, Kate Fish. Thank you so much for joining us. And be sure to tune in next week for another episode you will not want to miss.
If you guys like what you heard or saw today, please follow us on Spotify or subscribe on Apple Podcasts. And if you're feeling super generous today, please leave us a 5-star rating or a short review so more people can find our show. We will see you guys next week. And if you'd like to connect online, please follow the podcast at stop.collaborate-and-listen-pod on Instagram. See you guys.
See you guys.
Stop, Collaborate, and Listen is a space for real, honest conversations, but it's not a substitute for individualized care. Episodes may include discussions of eating disorders, mental health struggles, trauma, or other sensitive topics. Please take care while listening. The content shared here is for educational and informational purposes only and should not be taken as medical advice, a diagnosis, or a treatment plan. Listening to this podcast does not create a provider-client relationship, and while we speak from both professional training and lived experience, we're not here in the role of your personal healthcare team. If you're struggling with food, body image, or mental health, we encourage you to seek support from licensed, eating disorder-informed providers who can offer tailored care you deserve.